Hi, Brittany.
Hi,
Dr. Booth, I should say.
Brittany's fine.
Okay. I'm so happy that you're here. This has been oddly a long time in the making, but timing is everything. And
Mhm.
we're going to get into so many good topics today. Really, your passion is medication during pregnancy and breastfeeding and potentially fertility. We'll get there. And it's been in the news so much lately that I feel like you were maybe meant to digest some of that news before you actually came on so we could talk more about it.
Yes, I know. We've had to delay this a couple of times for random reasons, but like you said, it's just perfect timing so that we can actually talk about the things that have been in the news and dispel some of the misinformation that's a little bit more
Exactly.
prevalent out there.
So you are a psychiatrist.
Mhm.
How did you end up in this field, and how did you end up with this sort of niche specialty?
So I decided to go into psychiatry in general when I was in medical school. I went to med school actually to be an orthopedic surgeon and then got there and realized it's not for me. And I also don't have the upper body strength
Can I
to
just say
do
one
that.
thing? Like this, I need to do just a reel of all the doctors who come on who say what they went for and what they ended up doing because I don't think ever the same. I
Never.
love
Yeah.
that. I love that. Okay. So good. You didn't want to have to like use all of your muscle every day at work. I get that.
Exactly. And it was also, I realized, oh, that it's like an entire specialty of 95% men. And uh, that wasn't, turns out wasn't my vibe.
Yeah.
And so then I decided to go into psychiatry. And then when I was in my psychiatry residency training at UCLA, there's a reproductive psychiatry training clinic there called the UCLA Women's Life Center. And I signed up for it just thinking, oh, it's a sort of unique clinic that UCLA has, might as well take advantage of it. Um, and it turned out, sort of just timing wise, right when I was starting in that clinic during my third year of training, I was undergoing IVF, and then it worked and I got pregnant. And so while I was learning how to do reproductive psychiatry, I was going through pregnancy
Oh, wow.
and then had my baby, and I loved it. I had such a great experience that year. Had my baby, did my maternity leave, came back, and I actually did the clinic a second time as a chiefship during my fourth year. And now I was, during my first year of postpartum and experiencing that for the first time alongside learning all of it. And that year, I also was doing a rotation in UCLA's perinatal intensive outpatient program, which is a 3-day a week program for people with more severe perinatal mental illness. And again, just reinforced my love for it even more. And it just kind of clicked like, okay, this is my calling. This is just what I'm going to
Wow.
do forever.
Amazing. Let's get into, can we talk briefly about your own IVF journey? Did you go into IVF unexpectedly, or did you know that you might need help starting your family?
We knew. So my husband had testicular cancer
Amazing.
several years ago. And thankfully, he's completely okay. We caught it really
Wow.
early, intervened very quickly. And so he is completely fine. But because of that, when we were, looking into starting our family, we automatically did some fertility testing because we knew that there was going to be a good chance that we would need to use it. Um, and his numbers really showed us, this isn't, do a Clomid for a cycle or do
Right.
some IUI. This was sort of a
Go right for it.
go straight to IVF.
Can I
Yeah.
ask you a little bit about that? Because we talk a lot about the female oncofertility journey. We don't talk so much about the male. Did they even approach him at the time he was diagnosed to potentially freeze sperm, or was it not even a conversation?
I don't remember that being a conversation
Mm,
at that time.
yeah.
Yeah.
I'm just thinking, with women, they're finally starting to talk about it. Like generally it's with breast cancer, right? They're like, it's
Mhm.
invasive. You need surgery in like 4 days and we need to freeze your eggs before then. And women are like, what are you talking about? And for
Yeah.
women, it's so much, the weight feels so much heavier. Because for men there are more options, but I'm just curious if they brought that up ahead of time. Okay, we don't have to go down that rabbit hole, but I was just curious. Okay, so you knew you were going to need IVF.
Mhm.
And was your journey relatively easy, sort of knowing what the expectation was going in?
Yeah, at that time when we did IVF, it was very deceptively easy.
Yeah.
We did one egg retrieval. I was 31 at the
Mm.
time. So, relatively young, did one egg retrieval, got 10 embryos. We
Wow.
didn't even do genetic testing at that time. We implanted the highest graded one. It stuck. We got our wonderful, beautiful daughter. And then we froze the rest of them. Um, we have been trying to grow our family again, and this time around has been definitely more of
A
what I think
challenge.
a lot of people have
Yeah.
had in terms of their IVF journey.
I'm sorry. I'm sorry to pry into that at this moment that it's happening,
No,
but thank you for sharing it.
yeah.
Okay, so you decided that this was going to be your field, and how did it resonate with you personally in terms of I want to do this because I'm going through some of these things? And I'd love to hear that in terms of prenatal and also postpartum, perinatal,
Mhm.
the whole journey of it.
Yeah. So I consider myself very lucky that I myself didn't experience a perinatal, mood or anxiety disorder, but seeing and experiencing pregnancy, for the fertility journey, and then pregnancy itself, even just a normal, relatively easy pregnancy and a relatively easy postpartum, right? I didn't have any major birth trauma. It kind of went as expected. I had a lot of support in the postpartum. Um, Even having what is considered to be a relatively easy perinatal period, it was still the hardest thing I've ever done. And watching all of these women in the clinics that I was in, trying to do all of that, dealing with depression, anxiety, OCD, what have you, having less support than I had, less supportive partner or not as much family around, all of these other things that I was very blessed to have. Um, it just sort of felt like, oh my God, if I can help them at least get to a point where they're not depressed, not paralyzed by anxiety, and they can just have that baseline to help, garner that other support and garner that other, those resources that they need. That's that's moving the needle hugely for these women.
Hmm. Exactly. Okay, so let's get a little bit into the medication and pregnancy.
Yeah.
There's so much stigma, there's so much misinformation. Why don't we start there? Like,
Mm-hmm.
what are the main bits of misinformation that you deal with often?
Yeah. So probably the biggest one is, the assumption that you cannot take medication when you're pregnant. That they cause birth defects, they cause autism, they cause, all sorts of problems. Uh, this assumption was unfortunately reinforced a few weeks ago. There was the FDA advisory panel or quote unquote expert panel on SSRIs and pregnancy. And it was a panel full of very biased individuals who hold the same beliefs that this current administration does.
Mm.
And they were, really cherry picking individual studies that supported their own beliefs, and then cherry picking, uh, results and conclusions from these studies that actually weren't what the studies even said.
Mm.
Um, and so, you know, to combat that first part of misinformation, SSRIs, most of our psychiatric medications actually have a good amount of data in pregnancy, are not associated with significant increases in cardiac defects, birth defects in general, miscarriage or pregnancy loss, certainly not neurodevelopmental disorders, including autism. Um, it was just a whole bunch of fear mongering.
Mm.
And I would say that the next most common sort of myth or misconception is that okay, you can take a medication, but it has to be Zoloft, or
Yeah.
Zoloft is the safest medication to take. Um, and Zoloft is great. It has the lowest transmission through the placenta and into breast milk, but it actually doesn't have any different outcomes than any of the other medications. And so actually the real guidance is whatever medication you're taking that's adequately treating your depression, anxiety, what have you, you should stay on whatever medicine it is that's working for you. There's no need to switch
To
to
switch.
Zoloft. Yeah.
Wow. That is, I feel like that's for sure the biggest one I hear, other than the first one. Okay, just to be clear for everybody, can you describe the class of medicine that is considered an SSRI?
Yeah. So SSRI is selective serotonin reuptake inhibitor. It's our oldie but goodie antidepressant class. So these are the things like Prozac, Zoloft, Lexapro, Celexa, Paxil. There's a couple of newer ones that are like sort of hybrid SSRIs, but those are the sort of big ones that most people have heard of.
And what do you think is the reason that this potential administration wants to cherry pick certain data? What's the benefit of it?
Your guess is as good as mine.
Okay.
I've stopped trying to find logic and
Yeah.
rationality where I really don't think there is any. I think um, people have certain biases against medications of certain kinds, have biases against believing that mental health even exists. One of the again, quote unquote, experts on the panel was even sort of questioning the existence of depression,
Mm.
that it's just women experiencing emotions and we're pathologizing it. And so people have certain worldviews and beliefs, and they find evidence to support them rather than letting evidence inform what their beliefs are.
Mm.
It's backwards.
Mm. Okay, so back to sticking on your same medication. I feel like, even from personal experience, when your hormones are changing, which can be prenatal, fertility treatment, pregnancy, postpartum, all of the phases, your body composition, your brain composition, it does theoretically change.
Mm-hmm.
Is there benefit to switching meds to find something that meets the needs of a changing, like as the hormones are also changing your chemical makeup in your brain? Like, for example, my perimenopause journey is accompanied with anti-anxiety medication. And the further I get into perimenopause, I'm like, is it more anxiety or is it perimenopause? And which one do we treat? How do you figure that out?
So even though, during these hormonal transitions, your brain and your body are changing, um, it doesn't necessarily change your personal sensitivity or response to a particular medicine. So somebody who has historically done very well on a certain medicine, let's say Lexapro, for
Mm.
example, just because they're undergoing these hormonal transitions and their brain and their body are changing in certain ways, it doesn't necessarily mean that their responsiveness to Lexapro is going to all of a sudden worsen and that now Prozac or Zoloft is going to be the medicine for them. Overall, in general, if you are responsive to a certain medication, you will continue to be responsive to it. But you might need a higher dose or you might need some augmentation for it. But it doesn't necessarily mean like all of a sudden the right SSRI for you has switched.
Got it. And I feel like the point of all of this that we can get into as well is that a healthy mother provides a healthy child, no matter what,
Yes.
right? Like,
Yeah.
this is the crux of everything that we both feel passionate about. So let's just like destigmatize that piece of it. How are the benefits to the mother outweighing any risks?
So all of the studies that we used to have that people point to say, oh, look, SSRIs and antidepressants cause all of these problems. These are older studies that were not very well designed. And really what it was showing was that it was the underlying mental illness that is associated with poor outcomes. It was the underlying depression, anxiety that increases associations with miscarriage, stillbirth, birth defects, neurodevelopmental disorders, all these different, outcomes that people are really afraid of, preterm labor, low birth weight, all of these different things. So really, by treating the underlying mental illness, we're actually hopefully mitigating the risks of these poor outcomes. We may not be able to get them back down completely to the baseline population rates, but hopefully we're mitigating the risk of that increased risk. Now, again, we're also talking about associations. We're not necessarily talking about causation,
Yeah.
but still.
Wow. And if somebody is pregnant, because I assume that or let's talk about, you work with talk therapists.
Mm-hmm.
Do you feel that that's important, crucial? How do you feel like that relationship is needed? And then if somebody comes to you pregnant, and is it more important to just get them on some meds to balance things and then worry about the talk therapy, or do you like only get referral from a talk therapist at that point?
So it depends on the severity. A lot of my referrals do come in from talk therapists. So oftentimes, they're already in therapy. It's not quite getting them to where they need to be, or they have a psychiatrist. The meds are sort of working, but they need a little bit of tweaking. And so they'll come to me. But I think talk therapy during pregnancy, even preconception, sort of leading up to this huge life transition, is incredibly important. um, your entire identity changes during this time, and it can bring up a lot of things, even things that people think, oh, I've done the work for this in therapy, I put that to bed. It can bring a lot of things up from the past, and so working with a therapist can really help to untangle a lot of that as they go through this transition. But the decision, for me, if therapy by itself is enough versus we need to add on a medication, it really depends on the severity of what we're looking at. Um, if someone has a moderate to severe depression, anxiety, what have you, um, a medication is often recommended at that time. If it's a pretty mild case, or they just started therapy, they're like 2 weeks in, they've got a ways to go. Sometimes the recommendation is to continue therapy, and we'll closely monitor.
Mm. Do you find the trends are gearing more toward people wanting more medication or less? And by that, I mean, I feel like around the stigma, there's also, well, as a last resort, if I need to medicate, I will. And that's so unfortunate because in so many cases, it can be so helpful. Are you finding
Yeah.
that trend still, or do you think it's switching a little bit?
I think it's slowly trending the other way, where people are becoming more open to it. Um, I think especially when it comes to pregnancy, there is still that mindset of, as an last resort, or okay, fine, I'll take it, but at the lowest possible dose.
Yeah.
There is still quite a bit of that. And so in those cases, the counseling that I give is, first of all, like we said, healthy mom, healthy baby. It's really worth it for you to feel well. That does, we think, probably mitigate risk of these bad outcomes. But then when people are like, okay, I'll take it, but just lowest possible dose, I don't want to go any higher than such and such number. The guidance is you should take whatever dose you need to feel well. We're always targeting the minimum effective dose, but effective is really the operative word. Because there's going to be an exposure either way. And we really don't have any evidence to suggest that higher doses increase the risk for any adverse outcomes. So if you're treating it with too low of a dose, you're actually getting this double exposure of the medication plus the undertreated problem,
Mm.
which we know is associated with the bad outcome. So I would so much rather have one exposure to a higher dose of medication than a double exposure of a low dose medication plus untreated mental illness.
Such a good way to look at it. And it's just so strange because I think so much of that is just stigma based and or especially, I mean, we live in LA. So I think there's a lot of like stigma around being dependent on any form of medicine that you didn't work hard
Mm-hmm.
enough to figure it out yourself, which is, I think, BS, obviously. But
Yeah.
it's like I just think about people out loud who are like, well, I'm only on 10 milligrams of blah blah blah. And
Yeah.
it's like, is that even doing anything for you? You know, I mean, of course, it might be for somebody, who knows? But it's just such a great reframe of like, if it's not going to be the effective tool to get you out of this place, what's the point of taking it?
Why even? Yeah.
Exactly. What were some of the things that you felt surprised by in your own postpartum journey? And how did you, I don't know that you needed medication, but if you did, how does one who prescribes medication go about receiving medication?
Yeah. Um, things that surprised me postpartum, I think how long physical recovery took, even from a vaginal delivery. Um, I think there's the 6 week OB appointment, and that's when most people are cleared. Oh, okay, you can have sex again, and then it's like, you're kind of sent on your way. And so there's a sort of assumption like, oh, 6 weeks is sort of the physical recovery time. And then realizing, oh no, it actually lasts for a very long time.
Hmm.
Um, and then like we sort of said, the identity shift, I think, was a really big part of it for me, kind of um renegotiating who I was. Uh, I was mom now, but I was also still, a professional. I was still a psychiatrist. I was still, these two different people. But then it was also this question of who am I outside of those two identities? Because I, sort of lose time to do anything that hobbies, right? Like things that you just really like and enjoy. And so it, I felt like I lost sight of those other parts of me a little bit, and I wasn't really expecting that.
Mm.
And it took a while, even a couple of years, to really rediscover some of those other parts of myself, and what I enjoy and what I like doing, and incorporating those parts of myself again. Um, and then, in terms of finding a prescriber, it's hard. Being a reproductive psychiatrist, it's hard finding another reproductive psychiatrist that I don't have a personal relationship with.
Right. Right.
But there are certainly a lot of good ones out there if you look for them.
Mm. And I know that there's been some, like, let's tie together the insurance piece of things with
Mm,
some of these changes that are happening on a governmental level.
yeah.
This must be like the bane of your existence as far as your job goes. How does it work for these drugs? Are some of them covered? Aren't they? What do you have to prove to show that you need them? Like, how does it work?
So in reproductive psychiatry, we generally prefer older medications because the older a medicine is, the more data we have on it, right? So thankfully, most of the medications that we're working with, especially during pregnancy, are old generic ones that most insurances are going to cover. Um, where we in this field where we're finding more stickiness in terms of insurance coverage is for this new postpartum depression medication that we have called Zurzuvae. It's new, it's brand name, it's expensive. So that's the one that insurance companies are putting us through, a little bit more uh, of a ringer through.
Hmm.
So it depends on the insurance plan. Some of them are still fairly easy, where it's just a prior authorization, and we just need to say, this is an adult patient with postpartum depression that had its onset during this specific window. And they say, okay, approved. Some of the other ones want us to try a certain number of again, old generic cheap medications first before they'll approve it, um, which is annoying.
Yeah.
Um, but that's really the one where insurance coverage is the stickiest part.
And so if you have to do that, I guess you have to do that. So you'll be
Yeah,
like, okay, we have to give you a month of whatever Zoloft in order to see if you can then get the other one. And so you
get
have
the
to
other one.
put this woman's body and brain and the whole thing through adjusting meds. And
Yeah,
that is so frustrating.
yeah.
How long do you feel like it takes a person to adjust to a med? Is there a guideline there?
So Adjusting to it and responding to it, I think about differently. So
Hmm.
adjusting to a medicine, people will oftentimes have initial side effects when they're starting a medicine. It might be stomach upset, it might be headaches, it might be sleep disturbance or sedation. And oftentimes, those side effects that happen at the very beginning will subside after a few weeks. So I think about that as adjusting to the medicine versus responding to it. It can take up to 8, sometimes 12 weeks to fully respond to a new medication or a new dose. So, after that period of time, we can say, oh, we started you on Zoloft 25. It's been 8 weeks. We've gotten 10% better, 25% better. That's all we're going to get. We should increase the dose from here. So I think about it, adjustment and responding as two different things.
Yeah. And so then if you would, so for that person, if you decide to adjust and go to a higher dose, is there another general 2 to 3 week adjustment period?
Sometimes there's another bit of an adjustment period. Whenever you increase a dose, there's a potential for an increase in side effects. I'm not aware of any actual data on this, just anecdotally, though.
Yeah.
I find that the adjustment period when you're increasing a dose tends to be shorter, and those side effects generally don't tend to be as severe. So you might have a few days of some stomach upset, but not as long or not as bad as it was when you were first starting the medicine.
Got it. And
Yeah.
I think this is just for helping, like I feel like there's women who are having adverse adjustment effects
Mhm.
and are scared to keep going.
Yeah.
What do you tell? Are you more like, let's stick it out and see? Because I think it's like you don't know what the lesser of two evils is. And this is with
Yeah.
anyone and any medication. Do you continue to feel like crap, let's say, for the next 2 weeks to see if ultimately you get past it? Or do you immediately pull off? How do you make those decisions?
It depends on the severity. And people also have different levels of
Yeah,
tolerance
a different
for this sort of,
threshold. Yeah.
yeah, for this discomfort, distress, right? Some people are like, I can muscle through 2 weeks or 3 weeks of feeling like crap. Some people, really are put off by kind of any sort of
Hmm.
level of discomfort. So it depends on their own personal level of tolerance for it. And then it just depends on what are we looking at? How severe is this? Are we looking at, oh, we started this new medicine and you're now having new onset suicidal thoughts? No, we're cutting that right
Sure.
away,
Great.
right?
Yes.
Um, is it, is it stomach upset or sleep disturbance or things that I know I have a very high likelihood of resolving after a little bit. Um, if so, I'll see where they're at, and if they're open to it, I'll say I think we should try and give it at least a couple more weeks and
Hmm.
and see. Um, for me, it's all about meeting people where they're at, though, if they're willing to do it or not.
Hmm.
Um, and I think it depends on the psychiatrist too. I think some people are unwilling to go through that because they've had experiences where they've felt ignored or dismissed by their doctor,
Mm.
um, or invalidated. Like, oh, it's not that bad. Don't call me with these sorts of questions or problems, right? Versus having a provider who can validate the experience and and be responsive, to a patient's questions about it or outreach about it. So the patient feels like this is a member of my team. They really are on my side. They're there if I need them. Knowing that your doctor is there for you in that way can help you feel more confident going through that 2 to 3 week process versus I'm in this alone. And if I have a real problem, this person's not going to respond to me. So I'm just not even going to go do it.
Mm.
Right.
Yeah. Okay, will you do a fun like fire question with me? I'm just sort of experimenting with some new trial by fire questions. Okay,
Yeah.
they're easy, but let's start them with coffee or tea.
Coffee, 100%.
It's so funny. Everyone's very passionate about that one. Beach or mountain?
Mountain.
Okay. What is a wellness trend that you're actually into right now?
Ooh.
Or
I don't
an old one that you're still doing?
I don't know about a wellness trend because I've saying no, I guess.
That's a
Like,
good one.
yeah, just saying no to things.
I love that because boundaries in general are kind of trendy, even though they shouldn't be. I think that's a really good one.
Yeah.
Is there one thing that you'd never thought you'd be doing and now you love?
Um, I don't know if it's something that I never thought I would be doing, but I've been reading a ton of romantasy
Mm.
books.
And you
So
love
like
them.
fantasy, oh my God, love them.
Okay.
So I grew up with loving fantasy and like reading in general as a kid. Um, but I never thought like the romance part of it was going to be something that I would love as much as I do. But
That's a good
yeah,
one.
can't stop.
That's a great one. Okay, now finish the sentence. I feel most like myself when.
I'm well rested.
I love that one. Am I missing any? Is there any other amazing thing you want to tell people about SSRIs and pregnancy or fertility journeys?
If any doctor, pharmacist, any kind of medical professional is telling you you have to stop a medicine in pregnancy or you have to switch to Zoloft, get a second opinion. Um, Really, the only medicine that we have in psychiatry that is kind of like 100% absolutely not is a medicine called Depakote or valproic acid. It's a treatment for bipolar disorder. That's really the only one that I will say you cannot be on in pregnancy. Everything else, there's time to wait and get a second opinion from an expert in reproductive psychiatry to make sure. Everything else, you have a little bit of wiggle room.
I love it. It's so definitive and easy that way. And we're going to, of course, link out to you. You practice in California, you're licensed in California. So anybody in California can come find you. And you do
Exactly.
virtual as well, right? You do virtual.
Mm-hmm. Yep.
Amazing. Thank you so much for being here. And thank you for just really clearly speaking out for what we need. It's everything.
Thank you. It's been really fun talking to you.
Good.